Assalamualaikum doctors. In this video, I'm discussing how can we manage supraventricular tachycardia. So it comes on history also, video station it comes. So first we diagnose the supraventricular tachycardia. We do some investigations like blood, full blood count, peripheral blood film, blood culture. Inflammatory marker we are doing ESR, CRP and ferritin. Cardiac enzymes we are doing myoglobin, troponin, TNI, CKMP, BNP and LDH, D-dimer. Urea and electrolytes, that is creatinine, liver enzymes, ionized calcium, viral PCR, viral antibodies to exclude myocarditis and ABG. 12 lead ECG with rhythm strip. So during supraventricular tachycardia, what we find? Regular narrow complex tachycardia. Rates is 240 plus minus 40 beats per minute. PUFs is usually invisible. If visible PUF axis is abnormal and either precedes or follows QRS complex. Rarely regular broad complex tachycardia if aberrant pathway present. If in doubt, treat as ventricular tachycardia. What? In sinus rhythm. When in sinus rhythm, then Wolff-Parkinson-White syndrome, WPWS, pre-excitation with short PR interval for age and delta wave in 10 to 20% of children and can be normal. Imaging, we are doing chest x-ray to exclude other differentials and echo to assess the structural anatomy and cardiac function. So how can we management plan for SBT? First, resuscitate fast, ABC approach. Continuous cardiac monitoring with ECG recording with each interventions. Vagal maneuver, safe method only, should be explained and educated to parents. Diving reflex. Neonate and infant, we do diving reflex. What is that? That is use of ice bag over forehead and nasal breath for 30 seconds or wrapping infant in a towel and immersing face in iced water for 5 seconds. Then Valsalva maneuver, older children. Older children Valsalva maneuver, how you can do? Ask the child to blow into a 50 ml syringe for 15 seconds whilst lying down. Ask the child to stand for 30 seconds. Hold his legs for safety. In younger children less than 30 kg, gently hold the child upside down, then back to supine. We give adenosine IV, synchronized DC shock, general anesthetic must be given if responsive to pain, subsequent management, admit to HDU. Continuous cardiac monitoring, blood test to check for electrolyte abnormalities, urea and electrolyte, calcium and magnesium levels. Discuss with the specialist pediatric cardiology center. All patients will require pediatric cardiology follow-up, local or tertiary. So I am telling the algorithm of the management of supraventricular tachycardia. First we assess the conditions, then we check that shock present or not. So if shock present, we go the vagal maneuver if no delay, and if no, vagal maneuver. So vagal maneuver, first what we do? Establishing IV access quicker than obtaining defibrillator. So IV access we give, and we give adenosine 100 microgram per kg. After 2 minutes, if not controlled, adenosine 200 microgram per kg. Then 2 minutes, adenosine 300 microgram per kg. Consider adenosine 400 to 500 microgram per kg. Neonate 300 microgram per kg. Maximum 12 milligram. Then synchronized DC shock. Synchronized DC shock 1 joule per kg first we give. If not responsive, we are going synchronized DC shock 2 joule per kg. Everything with present of cardiologist. Then consider amiodarone. Other antiarrhythmia, seek advice. Do not use verapamil and amiodarone in the same patient, as both have negative inotropic effects. Do not use verapamil in children age less than 1 year. So verapamil and amiodarone together we will not use, and verapamil not less than 1 year. Understand? So first resuscitation. Then we are giving the child adenosine that is how much? 100 microgram per kg. 100 microgram per kg. Then after 2 minutes, adenosine 200 microgram kg. Then after 2 minutes, adenosine 300 microgram per kg. Still 400 to 500 microgram per kg. But neonate is 300 microgram per kg. That is 12 milligram. And then synchronized DC shock 1 joule per kg. Then not improving, synchronized DC shock 2 joule per kg. Then we consider amiodarone. Never give amiodarone and verapamil together because both have inotropic effect, and amiodarone is not given less than 1 year. So this is SVT management. Thank you. And also at the beginning, diving reflex, that is for neonatal infant we do ice immersion, and if it is a big child, older children, then we give the balloon. He will be blow the balloon in 50 ml syringe. Thank you.